Hello and welcome, everyone. My name is Kristen Talbot. I'm the program manager for MAVEN Project. Thank you all for joining us today and our friends at L.Rio for hosting today's session, What a Primary Care Provider Needs to Know About Chronic Kidney Disease with Dr. Lucius Wright. After fellowship, Dr. Wright became medical director of the dialysis unit at Brooke Army Medical Center and then director of the Nephrology Fellowship. After separating from the Army, he went into practice with the Jackson Clinic in Jackson, Tennessee, where he established the nephrology service and eventually grew it to 6 physicians. Dr. Wright retired after 35 years of practice, and during those years, he served as the clinic's chairman and the medical director. And now we get to be the lucky ones that have Dr. Wright as one of our MAVEN Project volunteers. So, Dr. Wright, when you're ready, please begin.
Good morning, everyone. Let me give you a few words about what we're going to try to do here, because I find that it's difficult to judge audience reaction on a Zoom call. I'm going to talk about what I think is important for you all to know as primary care providers about chronic kidney disease, but I got no way to get any feedback about whether you want more or less on a given topic. So I've got it set up to cover it in about 30 minutes, which leaves us a good 30 minutes to try to cover the rest of the topic. Based on your questions and your particular problem. So don't be shy, don't be bashful. I'm counting on you to help us make the hour productive for everybody. So let me go ahead and start my official part of the presentation here, if I can make my slide deck work.
Why would we want?
Yeah, we're in good shape. I think I just punched the wrong button.
Perfect.
I have some disclosures to say. First off, none of us have any content that's going to be talked about that causes a conflict of interest. We're not talking about any off-label uses or anything that's unusual or strange. And this project has been accredited by MAVEN Project for 1 hour of PRA Category 1 credit. So my objectives for the talk this morning are to let you understand what the eGFR tells you about your patient, and mostly what it doesn't tell you about your patient, because there are a lot of myths out there that I find confuse primary care docs. I want you to understand the importance of measuring proteinuria and what it tells you about the diagnosis, prognosis, and treatment of your patient. I want you to understand the basic approach to delaying progression of chronic kidney disease in patients at risk using ACE and ARBs, SGLT2 inhibitors, and finerenone. And lastly, I want you to recognize your role in helping patients achieve a dialysis last or never, as opposed to a dialysis first outcome. I've heard way too many people say to folks, oh, we can just do dialysis, but I've never found very many patients who wanted to do dialysis. I used to tell patients, I talked to a lot of folks over the years about this and only had 2 who thought it sounded like it'd be fun. And I thought they were nuts and could go to our nearby Western Mental Health Institute. So let's start with a case. This is a 36-year-old male who presented to the emergency room after a severe car laceration in a car wreck. He was noted to have hypertension with his blood pressure 190/110 on several occasions, and being the ER, they went and drew lab, showing a hemoglobin of 13.2 with normal indices, normal electrolytes, BUN and creatinine slightly elevated. He was referred to you in the outpatient department for follow-up of his acute kidney injury. So what do we know from this short presentation? We know that acute kidney injury is upcoding for hospitals, so there's a bias toward calling it acute, whether it is or not. If you check the records and they say something like WNL, which means either within normal limits or we never looked, because of course some people don't have prior lab. So there are things that you can look for when you're first getting started. Past medical history, for instance. Was he ever really sick as a kid, or was he told he had hypertension or an abnormal urinalysis? Perhaps he had a sports physical or a physical exam to get life insurance that showed that he had proteinuria. And there's some new observations about family history that I want to share with you. The classic hereditary chronic kidney disease is autosomal dominant polycystic kidney disease. It's the prototypical example, and there are 2 genetic markers with numerous subvariations, but they seem to be in the same area, which are conveniently referred to as PKD1 and PKD2. These can be tested for, but usually don't. An absent family history doesn't mean that the patient doesn't have polycystic kidney disease, but it makes it less likely. And there's always a problem trying to sort it. In the absence of the family history, is always a problem sorting out the difference between multiple cysts as opposed to hereditary polycystic kidney disease. We know more about these diseases and know that they're what are called ciliopathies. The problem seems to be in the flagella and the proximal tubule or the distal tubule, which become abnormal and lead to dilatation. There's some myths that are out there, one of which is that the families have a typical time to develop end-stage kidney disease. So, granddaddy went on dialysis at 45, daddy went on dialysis at 47. There's some of that, but most of that's just coincidental. It doesn't seem to be predictable when you look at large enough cohorts. And you have to be aware that patients sometimes present with pain, blood in the urine, and enlarged kidneys. And if you see cystins, so mostly on one side, you can be trapped into thinking this patient has a renal cell cancer and inappropriately do a nephrectomy. That's the classic example, the one you probably studied in school. The newer ones are non-traditional markers like ApoL1 and MYH9. Both have higher frequencies in people with sub-Saharan African ancestry and in locations with high frequencies of endemic trypanosomiasis. ApoL1 has gotten a lot of attention because it seems to explain a lot of what's going on in the family clustering in African American patients who have lots of members of the family. There's a town near here, for instance, where I've taken care of about a dozen members of the family who all had different kinds of kidney disease, but they all had kidney disease at a relatively young age and ended up requiring dialysis. We didn't know about what was going on at the time, but if we went back and tested, we'd probably find these folks had a double dose of ApoL1 as their particular problem. Some of you may be aware that your lab has changed the way it reports the estimated glomerular filtration rate, or the eGFR. The question I want to get into is, why has that been an issue? Measurement of glomerular filtration rate is central to the diagnosis of chronic kidney disease as an indicator for timing of clinical conditions, and now it's built into the coding system in ICD-10. Current lab formulas based on the newer method for measuring creatinine, which now go to the second decimal point, as compared to earlier versions, which only did it to the first decimal point. Most labs use a formula that was published in conjunction with the modification of diet and renal disease study, and originally was published with adjustments for Black race and all others. The process of changing the formula to eliminate this has begun, and it makes modest difference the first time you get a lab calculation from a different one. But the point I wanted to remind everybody of, and I'm going to say this several times during the course of this talk, is that E means estimated. It's not measured. If it matters, you should measure the GFR, or alternatively measure the cystatin C level, which can be done for about the same price as a creatinine. Urinalysis is still important. I find that since it involves somebody actually looking at it, it doesn't get done nearly as often as blood work for reasons that are obscure to me, because it's easy to pass urine. It's not necessarily easy to let somebody stick your veins. You want to be looking particularly for red cell casts, but they're rarely seen. I've only seen it 2 or 3 times. White cell casts and white cells are fairly common, but there's a tendency to write it off as a urinary tract infection. It may be, but it may not be. So keep in mind that you need a little bit of thought, consideration might be appropriate. And granular casts are non-specific and usually related to proteinuria. Protein is something that kidney doctors spend a lot of time paying attention to, because we think it's probably the most important prognostic indicator. It may be a marker of disease, but it's certainly a marker of prognosis. The worse the proteinuria, generally the worse the prognosis. The classic way of doing this is with the 24-hour urine, but anybody who's tried to do outpatient 24-hour urines knows there's a problem. So you can get the lab to measure on a spot sample the urine protein to creatinine ratio, or better, the urine albumin to creatinine ratio. It's also become a therapeutic target, and I'll show why that is in just a second. It is certainly a marker for comorbidity. This particular slide is an old slide that shows the proteinuria or albuminuria in funny units of micrograms per minute, which is not the way we normally think about it. But the picture shows rather graphically that the cardiovascular risk on the y-axis goes up rather substantially once the albuminuria exceeds somewhere around 6 micrograms per minute, and then levels off. It goes from normal at 1 to nearly twice as much by the time you get to 10. So it significantly is a marker for coronary disease. And this is a subject that we'll emphasize several times as well. The urine protein creatinine ratio can be done, but as I said, it's being replaced by the albuminuria as a better marker, because the urine protein creatinine ratio can be affected. This shows the relationship between the 24-hour urine protein excretion and the spot sample. And what it shows is that the more concentrated the urine sample, the less accurate the test is, the deviation from normal. If you have a dilute urine or isotonic urine, the ratios work tolerably well. So, you can use it if that's all you got, you make the best of what you got. But it is an issue to bear in mind that it does make a difference which one you test. All of this is designed to try to predict the risk of end-stage kidney disease. And I want to introduce you to something called the kidney failure risk equation. There's a 4-factor model and an 8-factor model. I find the 4-factor model works well enough for clinical use, and I've given you 2 websites that have a calculator. What they basically use is age, gender, estimated glomerular filtration rate, and the urine albumin creatinine ratio to predict risk. And they all overestimate the risk of this end-stage kidney disease because of the competing risk of death from cardiovascular causes. You'll recall that I just told you that the proteinuria is associated with the increased risk of coronary disease, and sure enough, it matters in the patient as well. Those will be in the slide deck. There are other diagnostic considerations, of course. Is this primary kidney disease or secondary kidney disease? More primary kidney diseases have specific therapies, but need expert consultation and laboratory workup and a kidney biopsy in most cases. So these would be the patients that you want to refer. Secondary is more common, which is mostly diabetes and hypertension in the US, malaria in third world countries. Screening for collagen vascular disease with ANA and complement is common, but may not be cost effective if you're dealing with a patient with limited resources, unless you got some clinical symptoms. Screening for cancer has the same problem. The most common lesion that you find on kidney biopsies in adult patients with nephrotic syndrome, for instance, is called membranous glomerulonephritis, and can be associated in a lot of cases with the PLA2R antigen, which can be measured in the blood. There's also one called thrombospondin 7A, which seems to be particularly associated with malignancy. But these tests, again, are not the sort of thing I would expect you to be trying to keep up with in a primary care practice. You got way too many patients to see to keep these kinds of details in your head. Infectious diseases, particularly syphilis, hepatitis B and C, and HIV, are reasonable in population supported. It is served in MAVEN supported clinics. And as I said, malaria is common worldwide, but rare in the United States. So those are some diagnostic considerations to think about. What I've said so far is that genetic factors are important, particularly in patients with African ancestry. Proteinuria is important, and albumin is better than protein for both diagnosis and prognosis. Kidney failure risk equations are available to estimate the 2- and 5-year probability of end-stage kidney disease, but overestimate the risk because of the competing risk of death from coronary artery disease. And I'm going to say it again, remember, eGFR means estimated. It's useful, but as a guide, not an absolute. Clinical status matters. So what are we going to do with this fellow that we've got here? He's got hypertension, so obviously he needs some blood pressure control. If he had diabetes, we'd need to do diabetes control. We'd want to avoid nephrotoxins. The biggest ones are non-steroidal anti-inflammatory drugs and proton pump inhibitors, both of which are available over the counter. And the goal of proteinuria reduction seems to be worthwhile in terms of delaying progression of disease, and consists of ACE and ARB, mineralocorticoid receptor antagonists, non-steroidal anti-inflammatory drugs in dire circumstances. And the new kid on the block that's getting a lot of attention are the SGLT2 inhibitors. And we'll talk about all of these. Let me share some thoughts with you on hypertension. ACE and ARBs are generally desirable because they're cheap. Hyperkalemia can be an issue. Volume control is a key issue, particularly in the patients with stage 4 and 5 CKD, and you need to usually use a loop diuretic because thiazides don't have much effect. An exception may be indapamide in the patient with no evidence of volume expansion, and maybe chlorothalidone. There was a paper in the New England Journal a couple of years ago that talked about adding chlorothalidone and getting a diuretic effect. But what's often overlooked is that those patients were also on loop diuretics, so it was really add-on therapy. Diuretic resistance occurs commonly in patients with nephrotic syndrome, Remember, the diuretics work from the luminal side of the membrane, and metolazone, which is additive, is often added to the mix to promote distal delivery of the drug, probably by direct action on the distal convoluted tubule. A lot of things to think about, but again, sort of inside baseball stuff. This is the part that I think is probably most relevant to primary care practices. Is there a blood pressure target that really makes sense? The Sprint final report showed 9,361 patients with hypertension at increased risk of cardiovascular disease without diabetes who were randomized to intensive, meaning a goal of systolic less than 120, or to usual goals of systolic blood pressure less than 140. And the goal was to reduce the composite outcome of heart attack, acute coronary syndrome, stroke, congestive heart failure, and death. The composite event rate was fairly low in either case, 1.77% annually in the intensive group and 2.4% annually. And the all-cause mortality was lower, 1.06 versus 1.44%. So this usually gets trumpeted as something like a 40% risk reduction associated with use of these drugs, which is true, but you're really talking about treating 100 patients to get one patient to get a benefit. So it's one of those things where it's generally a good idea, but again, it's about patient selection, because it turns out the intensive group had an increased risk of hypotension, syncope, and acute kidney injury. So there are downside risks to over-aggressive control. So again, the issue from my perspective is, what are you going to do at the basic challenge. Lower targets have lower event rates over the intermediate term, but at the cost of increasing complication rates, particularly hypotension and AKI. As always, it's a matter of patient selection, considering goals, competing risks, and the tolerance of medical therapy. I typically am fairly aggressive in young people, and by the time they get to 80, they've already outlived their usual expected life expectancy. So I'm not nearly as aggressive and much less tolerant of side effects. Remember, we're fond in medicine of this, the more is better theory, but it's rarely true. And aging occurs in everyone, albeit at different rates. So the goals for medical care change with age and comorbidity. So you need to keep updating with your patient because time and circumstances change. Let's talk about the SGLT2 inhibitors. This was kind of the study that started all this. This is the stories from 2020. But I've also stolen a slide that shows all the other studies. And what you've got is heart failure and heart studies, which are in the pink in the top, and those with chronic kidney disease on the right and with the blue dots. And these DAPA-CKD is the one that we just showed you the slide for. And you can see that the big difference is that the patients who are on the DAPA-CKD group have more proteinuria, which is what you'd expect. What you want to see here in this busy slide is the outcome of all the studies, the hazard ratio, which is the ratio of looking at the raw percentages. In DAPA-CKD, the risk of heart failure and chronic kidney disease was 60% of what it was from everybody who was in, and all the other things, a bigger and more impressive drop. When it was used in patients without diabetes, but who also had CKD, the result was about 50% reduction in hazard ratio. So this got everybody excited. But again, remember, you're treating a lot of patients to get a little bit of benefit. So it's hard to decide what to do. The DAPA-CKD study looked at a large number of patients, 4,304 with and without diabetes, estimated GFR between 25 and 75, and a urine albumin creatinine ratio between 200 and 5,000. The composite endpoint was a decline in eGFR greater than 50%, the need for dialysis, death. Trial stopped, and the trial was stopped early when the hazard ratio was 0.56 and treated versus control. And death occurred in 101 patients on the drug and 6.8% of the patients on the placebo. So renal protection seems additive for patients with established diabetic renal disease when combined with an ACE inhibitor. But currently, they're limited to use in eGFR greater than 25. That's an FDA thing, whether there's studies underway to try to see if that's necessary or not, but that's currently state of the art, and I would not recommend going past the current recommendations. It's associated with a natriuresis, which is its mechanism of action, and probably why they're particularly good in patients who have heart failure with reduced ejection fraction. But it's also associated with acute injury because, of course, these patients are on ACE and ARB and they're frequently diuretics, and they become volume depleted and their BU and creatinine go up. So you have to be looking for this when you use these drugs. They're costly. And the question at the patient level is, do you want to use an SGLT2 inhibitor, or would a GLP-1 inhibitor be a better choice? Some data suggests that the latter are better for heart disease, and they're certainly popular these days for weight loss. So, I don't have the right answer to that question, but it's a challenge to think about. The major risk besides the acute kidney injury seems to be Fournier's gangrene, which is a pelvic congenital urinary tract infection, which if you get it can be catastrophic and has a very high fatality rate. But the question is, how big is the risk, as it occurs fairly regularly? Certainly urinary tract infections because of the leukosuria are more common. Whether the life-threatening ones are or not, it remains to be seen. So what I've said so far, blood pressure control with ACE and ARB help delay progression. The goal is uncertain, but the 2021 guidelines recommend using sprint targets. But I do need to comment that the sprint targets were based on standardized blood pressure measurements, not what I did in my clinic and what you probably do in yours, where the patient comes in, one of your assistants just pops the patient in a chair, slaps on a cuff, squeezes it, runs it down, and writes a number down. What they did in Sprint was they put the patient in a room with choice of music on the headphones, usually quiet, soothing stuff, no loud raucous music. And they took 3 blood pressures using an automated blood pressure cuff and averaged the 3 of them. Somebody decided to look at the difference between the usual office blood pressure and the Sprint blood pressures, and the difference turns out to account for most of the difference in goals. The SGLT2 inhibitors are the new kids on the block, but in my view, it's still early days yet. So they're going to be more widely used, but we're figuring out exactly who benefits and who's not is yet to be determined. And the GLP-1 antagonists may also have a role to play, but where they fit is, again, also yet to be fully determined. Interesting stuff. We're glad to have choices, and I'm not fly blowing it. If you want to use it in your patients, good for you. But I just don't think it's standard of care yet. We want to end up talking about some data on renal replacement therapy. Dialysis and transplant are difficult medical regimens for the best of patients to follow. They involve restrictive diets, complicated drug regimens, dialysis either daily or 3 times weekly, clinic follow-up for transplant, and lifelong medications. So the question is your patient a candidate, and what can your patient expect on average? This slide I took from the 2018 annual data report, and it looks pretty good because it suggests that overall the mortality rate per patient year is going down. And it's currently in 2016, which was the last year of data for this particular slide, was averaging somewhere around 16 or 17%. And it's improved from nearly 22% in 2001. And that's probably true, but exactly what's causing that remains to be determined. There's a problem too with all of our data, because it turns out that the mortality rate in the first 3 months is quite a bit higher. It's about 20%. This looks at 1-year mortality from the same data set. And you can see that as many as 20% of your patients die in the first 3 months of dialysis. This is under age 65. With hemodialysis, peritoneal dialysis is quite a bit less. But that's probably patient selection, because the more stable patients typically end up on PD. So the question to ask yourself is, what would happen if you didn't do anything at all? And the answer is not much. Turns out the median survival once you get symptomatic end-stage kidney disease, not lab tests, but symptomatic kidney disease, is about 3 months on average. 6 months is not unusual. So it turns out that at least 20% of these patients would have been better off and gotten essentially no benefit from doing dialysis. And there are ways to get at that clinically. This is the most current slide available, which goes through 2020. And what you can see here is that the mortality ticked up, but it's actually been relatively flat. But it shows essentially similar data over a different period of time. Then the bump at the end is obviously COVID. And COVID hit the dialysis and transplant population fairly hard because of their immunocompromised state. So the things may be settling down, but the data aren't out. The 23 report hasn't been published yet, and nobody knows for sure what it's going to show. The question that's obviously important is considers when to refer to a nephrologist. If the patient's really sick, of course, you're going to want to send them to the ER or send them to the nephrologist. If the patient shows an active urine sediment, meaning lots of protein, lots of red blood cells, lots of cellular material, then a renal biopsy and aggressive therapy may be indicated. And you would want to consider it. In the patient that we talked about, start with referral. The referral is not urgent. He does need a urine albumin or protein creatinine ratio for determining end-stage kidney disease risk. And the thing I want to emphasize, and not to be negative about my colleagues, but nephrologists don't have any tools for medical management that you don't have. Monitoring quarterly lab work may be helpful to get an idea of the tempo of disease. And if the patient is a candidate for renal replacement therapy, so okay to wait till they get to stage 4. Most population studies suggest that 80% of patients with stage 3 kidney disease will not progress and will live to die of something else like coronary artery disease or car wrecks, but only time will tell. Given that this is a MAVEN talk, I do need to spend a few minutes talking about the problem of what the government refers to as undocumented aliens. Dialysis care in the United States is funded mainly by the federal government in one way or another, and they've determined that they're not going to spend the money on non-citizens. Some hospitals get disproportionate share payments through the state Medicaid program for emergency treatments, which are defined as pulmonary edema, severe hyperkalemia, or overt uremia, but not for routine dialysis. Arizona, which is our host clinic state, does have a program that will do that for people without papers. The two positions to take on this problem. One is the regular dialysis is the standard of care and is the just approach. The other says, do we have the right to spend other people's money? I don't have the answer to that one either, but I think that's the question. So what I've said is when working up a patient with newly discovered elevated creatinine, remember to assess proteinuria, treat hypertension as close to 125/80 as you can get without side effects. Use an ACE and ARB and loop diuretics, especially if they have chronic kidney disease. Remember, eGFR is just an estimate. It should generate thought, but not necessarily action. There was a paper that came out about a year ago that showed that the range of variation of eGFR from true GFR in patients with chronic kidney disease can be as much as 40% at the individual level. The estimates work pretty good at a population level, but not necessarily at an individual level. So if in doubt, you want to go by the patient. As the primary care provider, you have a role to play in assessing your patient's suitability for dialysis. Have a real conversation and don't take the view that, of course, you'll do dialysis when the time comes. No dialysis may be a more humane and appropriate option in the right circumstances. It's tough, it's difficult, but it is what we have to do. I used to tell folks that's what they pay us the big bucks for. So at that point, I finished my 30-minute introduction of what I think is important, and I'm going to get back to screen share here and there. Kristen's back online with us here, and then now we'll find out which ones I went by too quick, which ones I need to elaborate on, which ones I need to clarify what I said so that you understand. So use the chat function, raise your hand, whatever, and we'll go from there.
Yeah. Thank you so much, Dr. Wright. I don't see any questions yet, but we'll pause and wait for you to type them in or use the raise hand feature. While we pause, just a reminder that the CME survey is going to appear after this, after we close out of this webinar. If you get the email address that is affiliated with your MAVEN Project account, correct licensure. Yes, we've had somebody put their wrong licensure. Today's date, April 4th, 2024. And Dr. Wright's name, you will get your CME certificate immediately after completing. If any of those things are messed up, you'll still get it, or entered incorrectly, you'll still get it. It will just take a matter of time for us to fix it. While I continue to wait for questions, just a reminder that we also do specialty mentoring. So if chronic kidney disease is just something that you want to know more about, you can always sign up for a nephrologist mentor. We'd be happy to set that up. Question: can you comment on diet and slowing or preventing chronic kidney disease progression? Example, protein, sodium, etc., separate from hypertension control.
So the question is basically, does protein restriction make a difference in progression of chronic kidney disease? The modification of diet and renal disease study, which is now quite old, was a serious attempt to try to use modestly limited versus severely limited protein restriction. And the study was inconclusive because very few patients actually attained the complete restriction. What I tell patients is that I think it's a good idea to give up the big 16-ounce steak and go into the big Texan Amarillo is a bad idea because you don't want to be eating 6 pounds of meat. Not a good idea. Yeah, that question I can answer in a second. So basically, I think I take the Aristotelian approach that moderation in all things is good. So it's a good idea to do. Sodium restriction is a different question. Sodium restriction is frequently important for controlling edema. Most patients with chronic kidney disease are volume expanded. Their blood pressure will be hard to control if they're not volume expanded, and they do much better if they can maintain a steady intake of sodium. One of the things that happens with progressive chronic kidney disease is the time it takes to adjust to changes in dietary sodium intake slows. So they're more prone to edema, more prone to congestion, more prone to hypertension. And I do think sodium restriction is a good idea. Potassium restriction is an idea that comes about later on. So one of the things, for instance, I would routinely not recommend patients use salt substitute because it's mostly potassium chloride, which is okay when their GFR is 30, but not necessarily good when it's 15. So I don't want them to get in the habit. Okay, I got that one too. So the second question that came up was the KFRE equations. Those will be in the slide deck. There are two of them that I found. They both give essentially the same answer. So they'll be in the slide deck, and we can find that slide and show it back up. Third question had to do with bicarbonate control. And bicarbonate can be low, and the answer is it depends. The problem with bicarbonate is to some extent you have to give it with something else, which is usually sodium, of course. So you can get some volume expansion. I'll have to read that one in a second. Sorry about that. I'll leave that one for you, Kristen. It goes on to a second page.
You got it. Just in the Q&A box, it was kind of similar, but just does sodium bicarbonate help decrease the progression of kidney disease?
It's one of those things people like to think it does. I saw a paper in the last 6 months that said it couldn't show an effect. The problem that you got in any study that you want to show is good or bad is that the variability in progression is such that showing a difference between two groups, unless you got huge numbers, is very difficult. What I would use bicarbonate for is patients who have bicarbonate, say 18 or less. I do it mostly to try to reduce symptoms of dyspnea and things of that sort, and it probably helps later on with metabolic bone disease. But the goal isn't to necessarily make it normal, but to get it back up to around 22 or so. So that's the short answer of what I would do with somebody with bicarbonate. The average patient's going to run 20 to 22 without doing anything in particular. And what was that other question again? I lost track of that one.
The long one. Okay. Often when I refer patients to a nephrologist, they go one time and refuse to go back, saying, the doc didn't do anything you're not doing. I check renal panels and urine for microalbumin every 3 months, as well as prescribe appropriate meds. Any thoughts about this?
Yeah, I was early in my career. I had a fellow that I was seeing in the office who had chronic kidney disease. It was progressive, and he had a lot of family members and was young and otherwise healthy. So we basically were talking about transplant. And I had an access in him, and I sent him over to. He came in to see me to talk about transplant with his family members, and I talked to the potential donors in his presence, by the way, about what was involved for him and for them in the process. And after that was over, he said he needed to talk to me. He was becoming symptomatic, so I referred him to the dialysis clinic to start dialysis. Turned out that the access was not mature enough for the clinic nurses to be able to stick it, so we had to send him to the hospital to get temporary catheters placed. And in those days, we didn't have the kind you could wear as an outpatient, so we had to do it on an inpatient basis. And I was loading up the syringes to put some lidocaine into his femoral groin area to do femoral catheters. And he looked up at me loading on. I said, I didn't know you did anything like that. And I said, what do you think I did? And he said, all you ever did for me before was talk. So I've heard that too. True story. Took care of him on dialysis for years till he finally got a transplant. That's one of the challenges is that Patients with chronic kidney disease aren't sick. They see lab tests. They have lab tests that you see that mean something to you and gets you concerned because it's a number that looks higher than your comfort level, let's say. And so you want them to see the nephrologist, and the nephrologist is happy to see them in most cases. But what they're going to do is what you're doing. So it's not like your patient is going to get anything other than perhaps a conversation about dialysis. And then the patient's going to say, but I still make urine. I get up 3 times every night to go to the bathroom. I mean, I've heard that 1,000 times too. So, that is a challenge. And the problem is that you'll be well until you're really not well. And when you're not well, if you haven't got a plan and you're not executing the plan, you're behind the 8 ball. Because then you end up in the emergency room, you end up with a temporary catheter, which has a substantial risk of catheter-related sepsis, endocarditis, and death. So, I mean, it's the kind of thing where a good part of the educational process is to convince the patient that monitoring this every so often is a good idea. Early on, in stage 3 and early stage 4, I would usually tell the patients to come back in a year, but I wouldn't say in a year. I'd say come back when the daffodils are blooming or the dogwoods or whatever's blooming in your neighborhood right now. In Arizona, maybe the cactus, I don't know. Whatever was blooming, I say when it starts to bloom, think about coming back and let me just check in with me and see how things are going. And a lot of times you'd say, good news, your doc's doing a great job looking after things. You're doing a great job looking after things. Everything is stable. But sometimes you have to say, well, unfortunately, you've lost 10% of your kidney function in the last year. And age alone would normally expect you to lose about 1%. So at the present rate, you're likely to get in trouble in the next 3 to 5 years. Those kinds of things. So it's an educational process, but if you expect, if they're sent with the expectation that they're going to do something, the answer is no, they're not going to do anything because there isn't anything to do other than talk. So you can help avoid that problem if you set expectations on the part of your patient. If they go thinking they're going to see a surgeon who's going to cut it out and make it all better, no, we're internal medicine docs. We just talk about it. I used to tell people I try to get it better with jokes and pills and sometimes needles, but I didn't use knives.
Thank you. I don't see any questions, but we'll pause. We have plenty of time, so please feel free. If you have an in-depth question or you want to talk about a case or something, please use the raise hand feature so you can talk. And I promise I won't mess up the words then if you're the one asking the questions. All right. We'll wait. The awkward stare. Okay, so labs every 12 months, reasonable to assess for progression in someone with chronic kidney disease, correct? If worse, would you do more frequent monitoring?
Well, the answer to that sort of depends on where you are to start with. If you have chronic kidney disease stage 3, once or twice a year is probably plenty. If you got somebody with stage 4 and 5, probably every 3 to 6 months is better. And the more rapidly they're losing kidney function, the closer you need to check. And the issue is timing of referrals, because if you send the patient with stage 3 chronic kidney disease, as I said, the nephrologist is only going to talk to the patient. If you send them with stage 5 chronic kidney disease, the patient's going to want to try to get working on an access and all that kind of stuff. And that's hard to talk people into under the best of circumstances. But trying to talk them into it on a first visit is particularly challenging. I found that in general, the patients I've been seeing for about a year did better because I could talk them into the idea that if I put an access in, it meant I had it if I needed it, but it didn't mean I'd use it just because it was there. And there's a lot of fear on the part of patients that if I put an access in my arm, it means I'm really going to have to do dialysis. And the answer is yes, that's right. If you don't die of a heart attack first, you probably really are going to have to do dialysis. But it makes it real when you got an access in your arm, and then they have to deal with all the fear that goes with that, because it may not be fearful to us, but it is to them.
Thank you. All right, we'll pause one more time, see if there's any last minute questions. We've talked about the CME reminder, talked about specialty mentor. Oh, how likely is average patient to get a transplant?
Very few people get preemptive transplants unless they have a family member who's able to be a donor. So most people are looking at cadaveric transplants, which is now called deceased donors, but I prefer the cadaveric term myself, but it gets the same idea. And the transplant rate in the United States, taking the entire population of dialysis patients, runs somewhere between 4% and 8%, depending on which year you're looking at. So less than 10% is a safe answer to that question.
Thank you. And if you're struggling to think of a question, but you know that you're going to have a question after this, I'm notorious for always having questions after the fact. You can always reach out to Dr. Wright on our eConsult platform. He is there. You can type in your question, or you can even request a video consult. So please remember to use that. And if you have any challenges with the platform, the community portal, please let me know, and we'll be able to sort out that challenge and make it easy.
They can even make it easy for me, and I'm computer literate, but I don't like technology the way some people do.
It's fair. All right. Well, I don't see any more questions. So, Dr. Wright, thank you so much for today's session, and thank you all for joining us today.